Welcome to the conference session titled Understanding Low-Risk MDS. Thank you for joining us. My name is Alice Hauk, Senior Director of Patient and Professional Services at AAMDSIF, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help us manage the incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your healthcare. Today's specialist is Dr. Adrienne Phillips. Dr. Phillips is an assistant professor of medicine at Weill Cornell Medical College and associate attending physician at the New York Presbyterian Hospital. Dr. Phillips cares for patients with all types of hematologic malignancies or blood cancers, with a special interest in treating lymphoma patients requiring stem cell transplantation, and also in reducing cancer disparities by improving outcomes among underserved and minority populations, especially among Latino and Caribbean Americans. With that said, welcome, Dr. Phillips.
Good morning, and thank you so much for having me. Today I've been asked to give a talk on understanding low-risk myelodysplastic syndromes, or MDS, and I hope everyone can see the slides clearly and hear me clearly. With this new format during COVID, it's sometimes hard to know that there are people behind the screen here. But I have nothing relevant to disclose for this talk. And what we're going to do over the next 30 to 45 minutes are listed here in the objectives. First, I want to help you understand what MDS is. It's a challenging cancer to understand. It's not like breast cancer or colon cancer or lung cancer, where you know kind of where it starts and you know how it's staged. MDS is a little bit more complicated, so I hope to provide you with some more understanding of MDS, what the symptoms are, how it's diagnosed. We'll review how we as physicians are able to offer prognostic information for our patients, decide who needs treatment, when they need treatment, with what they need treatment. There's a scoring system which we use called the IPSS, which if you do have MDS, it's important for you to understand what that scoring system is composed of. And then we'll talk about some management options, particularly for patients with lower risk MDS. And here on the right, if you've ever seen a blood cell, on the bottom is a normal appearing white blood cell, particularly a neutrophil, and above it is just a cute little depiction of the letters of the alphabet in different shapes of the neutrophil. And that's what I hope to achieve today, is helping you understand the alphabet of MDS. So what is myelodysplastic syndrome, or MDS? First, I want you to know that it's plural. It's myelodysplastic syndromes with an S. And that's because it's not just one disease. It's really a heterogeneous group of malignant hematopoietic or blood-forming disorders. So hopefully you know that your blood cells are made in your bone marrow. Here on the right, we have a picture of a body with the hip joint, and you see that on the inside of the cortical bone is what's called the bone marrow. And both in the hip and in other parts of your body is where your blood cells are made. And what happens is in MDS is that your blood cells aren't made correctly, and your stem cells, which are supposed to go on to form normal red blood cells, white blood cells, and platelets, can't mature and develop properly. So this essentially leads to dysfunction and bone marrow failure, and inability to produce normal blood cells. And frequently this manifests itself when you go and you have your blood counts checked and you're found to be anemic or to have low white cells, particularly no neutrophils, which is a condition called neutropenia, or even low platelets, a condition called thrombocytopenia. So if you have low counts, I don't want you to think that this is always MDS, because there are a lot of conditions that mimic MDS, and some of them are listed here and some are not cancerous at all. So on one end of the spectrum, you can have other blood cancers look like MDS, leukemias, myeloproliferative neoplasms, when your bone marrow is making too many cells. It's not that they look abnormal, they're just too numerous. Those other, what we call heme neoplasms or heme cancers, can mimic MDS. But at the opposite end of the spectrum are benign conditions like nutritional deficiencies. If you're deficient in vitamin B12, folate, or copper, selenium, iron, if you have Crohn's disease and are not able to absorb vitamins well through your intestines, your blood cells need these vitamins for their production. And if you're deficient, you might have low counts, and this is not MDS at all. We would treat you with vitamin supplementation and your counts would improve. There are also some infections and medications. Alcohol can commonly cause low blood counts. Again, these aren't malignant conditions. And then some other conditions are congenital, you're born with them, they're immune related, or they're rheumatologic related. So another way to look at this is just in this diagram, which here on the left shows some benign, again, non-cancerous causes of low counts that could look like MDS. And I think I went through them on the prior slide. Interesting also, hepatic disease or renal disease. If you have enlarged liver, maybe your cells are hiding out in the liver and that's why you have low blood counts. If you have renal disease and you don't make enough hormone erythropoietin, you could be anemic, and that could mimic MDS, but it's not. And then here on the right are some of the non-benign, or what we call clonal malignant causes that look like MDS. And in addition to MDS, we've talked about leukemias, MPNs I've mentioned are myeloproliferative neoplasms. Your marrow is making too many blood cells. AA is aplastic anemia, and HMDS is hypoplastic anemia or hypoplastic myelodysplastic syndrome, where your bone marrow is not making any cells at all. And generally with MDS, you should see some cells in your bone marrow, but they look abnormal or dysplastic. But there is a form of MDS called hypoplastic MDS where you don't make enough cells. Another condition, PNH, could mimic MDS. In the last few years, there have been these conditions called CHIP or CCUS. CHIP stands for clonal hematopoiesis of indeterminate potential, meaning that maybe you have an abnormal mutation, but your counts are okay. We don't know what that's going to become. You're probably going to be monitored. That's not MDS. And again, lots of conditions can look like MDS, but they're not. So MDS is a disease of older patients. And here on this graph, we see that as you age, your likelihood of being diagnosed with MDS is higher. It's a condition that's more common in men than women for reasons that we don't know. And the average age of diagnosis is between the ages of 71 and 76 years. There are approximately 20,000 people diagnosed with MDS annually. And my hunch is that this is an underestimate because a lot of people may have low blood counts that aren't referred to a hematologist, that don't have bone marrow biopsies, and may just have a very slow growing MDS that is never diagnosed. So my guess is this is an underestimate. And when you're diagnosed with MDS, you can have a very variable course. Some people are diagnosed, they're completely asymptomatic. They just kind of smolder along and have no symptoms. Their counts stay stable for years. But there are a group of patients that unfortunately can have more aggressive MDS, need frequent transfusions, need therapy, and they can also transform to acute myeloid leukemia. And there are ways that we can predict for those things. So in terms of types of MDS, for the majority of cases, we don't know why MDS develops. That's called primary or de novo or idiopathic MDS. That's about 90% of cases. And again, we don't know why you've developed MDS, but certainly there are some secondary causes of MDS. Frequently, I see this in patients who've had cancers previously and got chemotherapy or radiation, and from the chemo and radiation that they needed, perhaps to cure their breast cancer or to cure their prostate cancer, they unfortunately had some DNA damage and now are diagnosed with what we call therapy-related MDS. And for these patients, it's highly variable. Certainly not everyone who gets chemo and radiation for a solid tumor develops MDS, but for those that may, it can happen really at any time after the exposure to the chemo and radiation, ranging from 2 to 10 years. And frequently, compared to primary MDS, secondary MDS is frequently more genetically complicated, having many different cytogenetic abnormalities. And that's important, as you'll see on a future slide, because we use these genetics to tell patients their prognosis. So in terms of symptoms, some patients are completely asymptomatic. They're going in for their annual medical visit. They have their blood counts checked and are surprised when their doctor says their counts are low. Others might have symptoms of low blood counts. So if your red blood cells or your hemoglobin is low, you might feel fatigued or pallor, develop shortness of breath, occasional chest pain while you're exerting yourself because of anemia. And anemia is the most common count or low count that we see in the early stages of MDS. So when the other counts are low, particularly the neutrophils, you might notice that you're having recurrent infections. When your platelets are low, you might have problems with bleeding or bruising. When you brush your teeth, when you injure yourself, you might have more frequent nosebleeds than you've ever had. That could be a symptom of MDS, particularly because your platelets are low. So how is MDS diagnosed? So obviously we take a medical history, and as I said, some people might have, a completely benign history. Certainly patients who've had a past breast or solid tumor who've been exposed to chemotherapy or radiation, we elicit that in your history. We do a physical exam. We still do that these days, looking for signs of anemia. Maybe your eyes are pale or your gums are a little inflamed. We check your abdomen to see if your liver or your spleen are enlarged. We look for bruising on your physical exam. But really, it's the lab studies that will give us the most suggestion of the diagnosis, and those particular labs are your blood counts. And we look at them not just quantitatively, but we also look at them under the microscope. Because we can see the cells. If they look dysplastic under the microscope, that might suggest the diagnosis. But again, because MDS can mimic so many other conditions, we want to rule out things. So we check for multiple vitamins. We check for that erythropoietin or EPO level. We look at your thyroid and we essentially we check for viruses. We try and rule out other mimicking causes of MDS. But if we're not able to rule those causes out, ultimately, to really establish the diagnosis of MDS, a bone marrow biopsy and aspirate is required. And we send the samples we obtain from this procedure for a lot of different tests, which I'll explain. Including flow cytometry, cytogenetics, and now molecular profiling. So I'm sure some listening in or viewing have had a bone marrow biopsy, and this diagram shows how it's done. I know in this diagram, it looks like the patient is kind of relaxed and, maybe getting a massage. It's really not a comfortable procedure, but hopefully in the hands of the right person, it can be less painful if you're using a lot of numbing medicine. And it really is an outpatient procedure that should take, about 20 minutes. So if we ruled out other conditions that mimic MDS, this is what's required. And essentially, in adults, we do a bone marrow biopsy and aspirate in the posterior iliac crest. So that's, the back of your hip bone. I do it like this with the patient laying flat. Some other providers might do it with the patient lying on one side or the other. And we use a small needle, which is shown to the right of the patient here. It's called the Jamshidi needle, which is actually a needle within a trocar. So we kind of bore a hole in the back of your hip bone, and then we take out that trocar and then aspirate the bloody contents of the marrow. And then we also take a small sample of the bone. And then we send this for various analyses, including cytogenetics, that's to look at your chromosomes, molecular diagnostics. We have a number of new ways to look for genetic mutations. And these are very important because it will help prognosticate what type of MDS you have. So what is a genetic mutation? So here, hopefully you remember from Biology 101, is a chromosome. You get one chromosome from your mom, one chromosome from your dad. And a genetic mutation is when you have an alteration of DNA on one of those chromosomes. And mutations actually occur every day, but our bodies are smart and we can fix them. And unfortunately, for people who develop MDS or other cancers, they're no longer able to fix those mutations and they propagate. And you can have mutations that are acquired, they just happen, over the span of your life. Those are called somatic mutations. Or you can have germline mutations, and these are mutations that are passed down and inherited from your parents. MDS is not an inherited condition generally, so the mutations that we see in MDS are generally somatic mutations. So this is an example of how we look for mutations and look at your chromosomes by essentially lining up all your chromosomes next to each other when they're in what's called mitosis. And I wish I could engage with the audience and test you and say, what's the normal complement of chromosomes that an adult should have? And in this picture, how many do you see? But because I can't get any responses right now, I'll give you the answer. So normally, as a woman, I should have 46 chromosomes and I should have 2 X chromosomes. A male should have 46 chromosomes, 1 X, 1 Y. And as you see in this diagram, this patient actually has 47 chromosomes. They have an extra copy of chromosome 8. This is a woman because you see there are 2 X chromosomes, but this woman has 3 8 chromosomes, and that is called trisomy 8, meaning she has 3 copies of chromosome 8 instead of the standard 2. And this is a genetic abnormality we sometimes see in MDS, about 10% of cases. Another abnormality we see is in MDS frequently patients are missing a part of the arm of chromosome 5. So here in the upper right corner, you see 2 chromosome 5s, but patients who have 5q minus MDS are missing a portion of that chromosome 5. And that's important because 5q minus MDS actually has a different treatment than other types of MDS. So another way we can look for chromosomal abnormalities is by a process called fluorescence in situ hybridization, or FISH. And essentially what's done with FISH is that we use a fluorescent probe that's linked to a DNA probe. And here in these cells, we see both pink and green colors, and they are highlighting particular segments of DNA on chromosomes here, 8 and 21. And in these smaller cells, you see 2 pink fluorescent dots and 2 green fluorescent dots. That's appropriate. That means this FISH is detecting DNA on chromosomes 8, and there are 2 chromosome 8s there, and then on chromosome 21, there are 2 chromosome 21s there. But in this bigger cell, we see another way that we can diagnose trisomy 8, and that's because the FISH probe is highlighting 3 regions of chromosome 8 instead of what would be expected, which is 2. So this is another example of how fish would detect trisomy 8. So once a diagnosis of MDS is made, we've done the blood test, we've done the bone marrow biopsy, we've gotten the results. We need our pathologists to help classify the MDS. And then once it's classified, we can then determine a patient's risk or prognosis. And the classification systems you'll hear about when talking about MDS in the old days was the French American British system, or the FAB system. And now that has been replaced by the WHO, or World Health Organization system. So normally in 2021, we're looking at the WHO classification of MDS, and then we're using these scoring systems to render a patient's prognosis. So the old FAB classification system had these subtypes of MDS, including refractory anemia with ring sideroblasts. That just means that there's certain cells, there's sideroblasts that have a ring appearance to them. This is something that pathologists will tell us. Refractory anemia with excess blasts means that blasts are immature cells. If someone has leukemia, they have more than 20% blast leukemia cells in their marrow. And someone with MDS could be converting to acute leukemia when they have excess blasts. They don't yet have 20%, but they have more than the 5% that's allowed in the bone marrow. So those are refractory anemia with excess blasts. Refractory anemia with excess blast and transformation means it's kind of on the border of becoming an acute leukemia. And then chronic myelomonocytic leukemia, or CMML, is another distinct form of MDS in the FAB system. But as I mentioned, more commonly in this day and age, we're using the World Health Organization system. I'm not going to go through them all. Essentially to say that the WHO system looks at how many counts you have abnormal, whether it's just a single count, like your red blood cells, or whether it's 2 counts, like your red cells and your white cells, or if it's 3 counts, all 3 lines are suppressed. And then the WHO really looks at these genetic mutations that I was talking about earlier, the trisomy 8, the deletion 5q. And based on your genetic mutations, the WHO system is able to offer a subclassification system. But to essentially make it less complicated, MDS patients have what we call dysplasia, so some abnormal appearing cells in more than 10% of their bone marrow cells. But importantly, this is less than 20% blasts, which would be the definition of leukemia. So once we have the subtype of MDS identified, we want to tell a patient's prognosis and determine the best treatment. And to do this, we use something called the IPSS-R, or the International Prognostic Scoring System, which has been revised. So this scoring system takes into consideration 5 variables: your hemoglobin, your neutrophil count, your platelet count, how many of those blasts you have in your bone marrow, and then finally, what genetic mutations you have. And depending on how many of these factors you have, we can classify you into having very low risk MDS, low risk MDS, which is the topic of this talk, versus intermediate, high risk, and very high risk MDS. And just for an example, this is how we might calculate someone's IPSS-R score. If I'm seeing a patient by the name of Margie, she's 78 years old, and she has MDS, and I'm going to go through her factors. Her hemoglobin is 8.2, so that's low. That would give her a point on this IPSS-R calculator. Less than 10 gives you a point. But her neutrophils, her absolute neutrophil count, her ANC, is okay. It's 2.3, so that's good. She doesn't get a point for that. The platelets are completely normal at 240. She doesn't get a point for that. And then her bone marrow biopsy shows 1% blasts, which is allowed. You're allowed up to 5% of blasts in the marrow. So that's another good thing. And then we send her genetics, and she comes back with 46 XX chromosomes, no alterations, no trisomy 8, no deletion 5q, no complex abnormalities. So having a normal complement for a woman of chromosomes 46XX is also a good thing. So plugging in this into her calculator, she ends up getting a score of 2, which puts her in the low risk category, which is good. The lower the score, the better. And this is demonstrated here in what we as oncologists use all the time to predict survival is what's called the Kaplan-Meier curve. And the way we read this is here on the x-axis is survival in years. On the y-axis is the percentage of patients. So we just said Margie was low risk, so she's on this green line. And if you go to, what we usually do is go to 50% of patients. So half of the patients with low risk disease, if you follow the 50% line over to where it intersects the green line, they're going to have an overall prognosis of about 6 years. So that for MDS is pretty good. If she was very high and had a very high risk MDS and had, let's say, all 5 of those factors, she got a 0.4. 50% of patients who have very high risk MDS, unfortunately, only live under 2 years. You follow the 50% line over to the red curve, and you can see that their survival is shortest. So this is how we're able to offer prognoses to our patients. And we can use this score not only to determine a patient's overall survival, but also their risk of transforming to acute leukemia, which is always a possibility for someone with MDS. And here for Margie, she's low risk, so 50% of patients should actually not transform to acute leukemia, at least when you follow this out 12 years, because she's very low risk. And not only will she survive many years, but her likelihood of transforming to acute leukemia is quite low. And again, you can compare that to someone who's very high risk, who 50% of patients might transform to acute leukemia within 2 years. So generally speaking, MDS is not a curable disease. I say that generally because I'm also someone who does bone marrow transplant, and certainly with bone marrow transplants, we are able to cure some patients. But we have to select those patients very carefully. And in terms of the general management of patients, we have different approaches for someone who has low risk MDS and someone who has high risk MDS. And just because we're not always able to cure patients with MDS doesn't mean that we cannot offer them good treatments and improve their quality of life. So the goals for patients with low risk MDS are to improve their blood counts. For those that are anemic and require transfusions, where our goal is to help them require transfusions less. We'll talk about transfusions shortly, but although transfusions will raise your hemoglobin, there's also a risk of making someone iron overloaded. So we don't want to give too many transfusions, or we want to be able to chelate some of that transfused iron off. So our approach is to lower iron levels in low risk MDS patients. We also have a goal to create more tolerable treatments, improve quality of life, improve their survival, and ultimately cure. With high-risk MDS patients, these patients have more aggressive disease. These patients are generally getting chemotherapy and treatments earlier on. They're perhaps referred for transplant earlier on. And our goals in high-risk disease are to decrease disease burden, also to improve cytopenias, lessen transfusion risk, and improve quality of life. So some of the treatments that we have available for patients with low-risk disease are actually what we call best supportive care and close monitoring. Not everyone with MDS needs treatment, and particularly for someone like Margie, who has low-risk MDS, a hemoglobin of 8, is perhaps not symptomatic, we would just monitor her counts. And certainly this can create a lot of anxiety, but there's no reason to treat her because she's asymptomatic and her counts aren't at the level where she's becoming symptoms, and they might not ever get there. But for those patients who do have symptomatic anemia, we'll offer blood transfusions with iron chelation. If they have a low EPO level, we might offer them erythropoiesis stimulating agents, or ESAs. These would be like the procrets or the epogens, the aranesp that maybe some of you have heard of. I mentioned for those who are missing a part of chromosome 5, those with deletion 5q, there's a specific therapy called lenalidomide for those patients. In the last year and a half, we have a new agent approved for patients with MDS who have the ring sideroblast subtype, and that's luspatercept, which is an agent that can increase hemoglobin. For patients who need chemotherapy, there are medications called hypomethylating agents. They're given both IV, and now we have an oral version that we might consider. I mentioned that some mimics of MDS are actually related to autoimmune disease. And if someone has perhaps an autoimmune component to their MDS, we might offer immunosuppressive therapy in select situations. So with regard to anemia, many patients need red blood cell transfusions. More than 80% of MDS patients will need a transfusion throughout their life. These transfusion needs vary. Some people may need them once every month or every 3 months. Some patients may need them every week or every 2 weeks. It really just depends. And transfusions can help patients feel better, become less anemic, improve their quality of life. But again, we worry about chronic transfusions leading to iron overload. So when we're transfusing patients, we also have to consider iron chelation because our body has no mechanism to excrete excess iron. And iron, when you're iron overloaded because of transfusions, iron can deposit in the liver and the heart and the bone marrow, and you can develop secondary liver failure, heart failure. So iron chelation therapy is used to remove excess iron, and we're able to monitor iron levels to determine if the chelation strategy is working. And it's really important for patients to be compliant with iron chelation for optimal results. So this just shows an algorithm of how we might treat anemia. Like I said, if patients are mildly anemic like Margie, no symptoms, we'll just observe. But if patients have moderate to severe anemia, we could check for that chromosome 5q deletion. We can also check for an EPO level. If they're 5q deleted, the medication lenalidomide will improve their hemoglobin. If they don't have the 5q deletion and their EPO level is low, we can replace EPO with procrit, epogen, aranesp. If their EPO level is high, again, we have this new agent, luspatercept, which can increase their hemoglobin. And just a little bit more about these erythropoiesis stimulating agents, or ESA. The examples listed here are epotin alpha or darbepoetin, which is aranesp. They stimulate red blood cell production. They're usually sub-Q injections given either weekly or a few times a week. This graph here on the right just shows a study that was done that compared in the dashed line people who did not get, the dashed line patients who got placebo compared to the dotted line patients who got the ESA. You can see that patients who got the ESA in the dash versus the dotted line were more likely to become transfusion independent. But interestingly, and I mentioned this before, patients responded better to EPO if they had a level below 200. So this solid line is patients who had a level above 500. They didn't respond as well. There are some side effects we worry about with ESAs, including headache, joint pain, high blood pressure, and rarely blood clots. So I talked briefly about lenalidomide. The brand name is Revlimid. It's indicated for lower risk MDS patients with deletion 5q. It's an oral pill, which is nice. 70% of patients who take this will no longer require transfusions. And interestingly, patients who also take this will have disappearance of the 5q abnormality, and they're reverted back to their normal complement of chromosomes. There are some side effects of lenalidomide listed there. And then this diagram is just showing how chromosome 5 is missing a little piece of it. And that's what we call deletion 5q. Luspatercept is a medication that's been approved in the last year and a half for lower risk MDS with ring sideroblasts, particularly if patients don't respond to erythropoiesis stimulating agents or have an EPO level above 500. It's a sub-Q injection. And in patients who met this eligibility, almost 40% of patients had a reduction in their transfusion requirement after 6 months. And here on the right, this diagram is just showing how luspatercept works. Essentially, when you have a ligand bound in its proper location, this ligand is preventing your red blood cells from maturing. But luspatercept is able to kind of trap that ligand and remove it from its natural binding site, and therefore allows red blood cells to mature correctly. There are some side effects, including low back pain, fatigue, nausea, diarrhea, and dizziness. So in patients who have more than anemia, those with thrombocytopenia, that's low platelets, or neutropenia, low neutrophils, or patients who have excess blasts, which are the leukemia cells, we have options including supportive treatments. Particularly, this might be elected in some elderly patients who have comorbidities where therapies could be more toxic than we want. But we also have hypomethylating agents and immunosuppressive therapies. And then if these treatments don't work, we have clinical trials available, which I would encourage everyone to participate in, because that's how we are able to learn about new effective medicines for this condition. And then bone marrow transplant is curative in some patients with MDS, particularly higher risk MDS patients. So this slide just talks about hypomethylating agents, which is a form of chemotherapy. There are two types, azacitidine or decitabine. They're given either in IV or sub-Q formulations, but in the last year and a half, we do have an oral formulation available. It's important to know if you're started on these therapies, your counts might actually worsen before they get better. So you just have to give these therapies time to work. And they're generally given either on a schedule of days 1 through 5 or days 1 through 7, and then repeated every month. And side effects include nausea, constipation, as I mentioned, an initial worsening of blood counts. But in this graph to the right, again, we see that patients in blue getting azacitidine compared to patients in red who got kind of conventional supportive care, azacitidine was able to help patients live longer. So that is why we offer this therapy for the correct patient. So now turning to things that you can do as a patient and family member to manage symptoms from MDS. So certainly in patients who are fatigued, you should do your best to get a good night's sleep, rest throughout the day. Counterintuitively, exercise is actually very important, but you should do what your body can do and not overdo it. Take short walks, ask for help with tasks, and particularly things now like delivery services. I know depending on where you are, there are a lot of options to have things brought to you. So take advantage of those services. In terms of managing bleeding symptoms, when you're brushing your teeth, use a soft toothbrush. Consider not flossing if your platelets are very low. Use an electric razor as best as you can. Try to avoid injury. and not taking supplements. This is actually important because there are some supplements that can worsen your risk of bleeding, like St. John's wort, things that are sold over the counter that you might think are helpful. Always review them with your physician because many of them can cause problems with bleeding. In terms of what you can do to help with infection, particularly in this era of COVID, good hand washing, keep your distance, don't share utensils or drinking glasses, eat foods that are well washed, well cooked, avoid crowds, keep a thermometer at home, monitor your temperature, and sometimes we offer MDS patients preventive antibiotics to prevent recurrent infections. So I talked about the several options for treatment, including one of which is supportive care. But for other treatments, our goals are to improve counts, hopefully manage and improve symptoms, improve survival, and avoid progression to acute leukemia. And for each individual patient, the treatment decision is going to be varied based on your age, what subtype of MDS you have, your other medical problems, how active you are, what your goals are, and not everyone's treatment is going to be the same. In terms of involving your partner in your care, you and your family should take a partnership role with your physician in managing your MDS. So things that you should know and perhaps write down, keep in a journal, are that IPSS score that I mentioned, your blast count from your bone marrow, your blood counts. Certainly ask your doctor about different treatment options and the risks and benefits and alternatives of each one, and then look for resources that can support you, including those listed here. So with that, I will conclude this presentation, and I'm happy to take any questions or comments. Thank you.
Thank you, Dr. Phillips, for your excellent presentation. We do have several questions. This is a question of clarification. Is MDS officially called a blood cancer or cancer?
MDS is a blood cancer. I'm not sure I understand that. Is the question, is it cancer or not cancer, or?
Well, I think they just want, I read it as worded.
is a cancer, and
Okay.
more specifically, it's a type of blood cancer.
I think that's, yes.
Cancers, you can have cancers, like I mentioned, of your skin, of solid organs like breast, lung, kidney, colon, liver, and then cancers of the blood. MDS is a type of blood cancer. I think, in years prior, there's been some description of MDS as like a pre-cancer or pre-blood cancer. MDS is a blood cancer. It's a slow-growing cancer. And I sometimes use the term maybe pre-leukemia because, all MDSs ultimately can become leukemia if given enough time, if you have the right risk profile, but it's not leukemia, which is probably the prototypic blood cancer, if you're thinking of it like that.
Thank you. I think that's the clarification that was needed. Another question, would you recommend patients with low risk travel out of the United States?
Pre-COVID or during COVID? Are you vaccinated? Are you not vaccinated? Are you going to a high-risk country or a not high-risk country? I mean, these questions are so complicated in this day and age, and I think we're all, frustrated living with the restraints of COVID. We definitely want to see our family members, our friends that might live abroad. Someone with MDS has a blood cancer, so they would be considered immunocompromised. I would certainly make sure you're vaccinated for COVID if you're eligible for vaccination. And, depending on your blood counts, your history of recurrent infections and where you're traveling, you have to take precautions and avoid crowds and, not travel with anyone who's known to be sick, which is kind of hard because going through airports, people are coughing all the time. I don't want to say I don't recommend travel, but I think you have to weigh the risks and benefits. And if you are to travel, which I do think is okay, make sure you're vaccinated, make sure you're wearing and using the appropriate precautions. And I would just say further than that, you'd have to talk with your physician about your own specific situation.
Thank you. At what point with your platelet count do you start treatment for lower platelets, but all other counts are holding steady? And what is the treatment?
Yeah, so platelets have to be pretty low for me as a hematologist to worry about them. So normal platelet counts is usually above 150, if that's a reference range you're familiar with. Generally, if you're having procedures, like if you're going to the dentist, if you're having any kind of elective surgery, the dentist, the surgeon might want your platelets above 100, above 50 for certain things. As a hematologist, if you're not going for procedures, if you're not having problems with bleeding, if I see a platelet count that's as low as 20, I just monitor. And I think, if patients are having problems with bleeding, I would consider blood transfusions. There are some medications that can raise your platelet count that I would consider, but I would have to look at it in the kind of perspective of your other counts, how you're feeling, what complications you've been having. I would say isolated thrombocytopenia in MDS is relatively rare, so we don't have too many patients that just have low platelets by itself. Usually they're also low neutrophils. Many patients are also anemic. So those with just isolated platelet counts, I would treat if they were less than 20, and then consider treatment with transfusion or medications if they're between 20 and 100 if they're going for procedures.
Thank you. This person was told that their MDS was not inherited in 2014, but then was told it is inherited in 2021, and they're a bit confused. Can you clarify?
So generally speaking, MDS is not inherited. You've developed mutations as you've aged over life. You weren't born with these mutations. There are some bone marrow failure syndromes. I think it was listed on one of the slides that you can inherit. I don't know how old this person is, but sometimes, for the most part, inherited MDS syndromes or bone marrow failure syndromes are diagnosed in the pediatric population, but I'm an adult oncologist, and I've certainly diagnosed, I'd say, patients up to maybe 45 that went unrecognized. The only thing that I could think may have changed between 2014 and 2021 is that we have more sensitive and more testing that we can do to test for germline mutations. And that might have been a test that's now available that may have changed the thought of why you developed the MDS.
Thank you. Next question is, if you had breast cancer and radiation and chemo drug, what are the most known chromosomes affected that have been identified as potential causes of MDS?
That's an excellent question. Someone with breast cancer who's particularly had a medication called adriamycin, and then certainly radiation, although breast radiation now is so focused on the breast and not extensive. But the general mutation we see is something called M11Q. If you've developed an MDS from prior adriamycin or radiation, but it's not always the case. And the general recommendation for breast cancer patients who've had chemo and radiation and are now cured of their breast cancer is just to have their blood counts checked once a year. And that's to look for any of these abnormal blood counts that might suggest an MDS.
Thank you. For low intermediate 1 risk, which treatments in clinical trials currently ongoing do you feel have the potential in reducing transfusion dependence?
So I don't know if this patient has had prior treatment or not, but there are a number of clinical trials. I think the eligibility changed, so I don't want to comment on a specific one, but I would encourage anyone with low risk MDS to look at trials that are geographically available to them. I don't know if the question's about a specific trial, but when you're looking at trials, there are also different phases of drug development. So I don't know. I would probably say something that's in phase 2 or phase 3 development is probably a little bit more promising than a therapy that's in phase 1 development. And then obviously you need to be near the treatment center where it's offered. But there's some trials that are looking at targeting specific genetic mutations. There are trials that are looking at oral versions of drugs. Many of these trials have very strict eligibility, so sometimes you're not always given the option of choosing which trial you want to enroll on. It's kind of which trial you're most eligible for. And then the other thing with clinical trials is, it's as physicians, we like to play chess and we don't want to make a move that's going to eliminate future moves. So I would say your strategy should be to talk with your physician to kind of line up possible treatment strategies over time, because you don't want to be on a trial that then prevents you from getting another therapy later on. You want to create more options instead of minimizing them. So I really think you have to talk with your provider about this.
Thank you. Are there any supplemental vitamins or nutrients you would recommend that would help increase my white blood cell count, red blood cell count, and platelets?
That's a great question that I get all the time. And certainly, before we make a diagnosis of MDS, we rule out nutritional deficiencies. So I would say you should ask your doctor to check for multiple nutritional deficiencies. Some of them I listed: vitamin B12, iron, folate, selenium, copper. But more often than not, patients with MDS, like I said, are iron overloaded, not deficient. So I would not recommend supplemental iron. And generally, the other vitamin levels are at their appropriate level. So vitamin supplementation is generally not recommended unless you're deficient, because we also don't want the opposite occurring, that you become toxic from too high vitamin levels. So I would say you should eat enough nutrients for a well-balanced diet, perhaps have your level checked. And depending on your circumstance, generally vitamin supplementation is not going to improve the counts for someone with MDS, because frequently they're already okay.
Thank you. If hemoglobin has been in the 9.0 to 10.0 range for 2 years, is this a sign of low risk MDS?
So we would have to take into consideration not just your hemoglobin, which is part of that IPSS-R scoring system we use, but also your blast count, your molecular mutations, your platelets. So you'd have to plug in all your values in that calculator I used. But it sounds like if your hemoglobin has been stable for 2 years, that's fantastic. That's generally not the range I would consider transfusing someone. If you're not on any therapy and it's stayed stable for 2 years, that's definitely low risk MDS. And as we saw from those survival curves, your prognosis is good.
Thank you. This is somewhat detailed, and I'm happy to repeat this if you need to clarify anything from this question. This person is at very low risk, MDS SLD, stage 3B, GFR32. Their nephrologist said anemia would contribute to high output heart failure. What does this mean? Are they at peril?
Okay, I think I got the gist of the question. So this is someone with low risk MDS, but also has chronic kidney disease. The GFR is the glomerular filtration rate, which is a measurement we use to assess kidney function. So someone who has kidney dysfunction and MDS has to be careful of what medications are used because they could worsen the kidney dysfunction and push you to needing dialysis, which is what we wouldn't want to do. Patients with um, kidney dysfunction frequently have a low EPO level, so the nephrologist might suggest, in conjunction with the hematologist, replacing that EPO hormone to try and stimulate or to supplement the hormone your kidneys aren't making to see if that can raise your hemoglobin level. The point about high output cardiac failure, I'm not sure I can answer because there's probably other medical things going on. But I think the gist of it is, given your other medical problems, I don't want to say you're at peril. We just have to be cautious about the medications we're using, how fast we try and correct your hemoglobin. Maybe for you, normalizing your hemoglobin is not recommended, but we want to just make sure it's in a range where you're not symptomatic from anemia anymore. But it sounds like there are multiple things going on. So it sounds like you're seeing your nephrologist, hopefully also seeing a hematologist, and they're both talking to each other.
Thank you. And one final question. This patient has an uncanny feeling strong in my gut that a particular prescription would be harmful to me. I'm 78. 3 times in my life, my gut instinct has been correct, and I now face a similar gut instinct firmly. How do you evaluate a patient's gut, or basically their instinct that something may not work for them?
So I always listen to my patients, and they know their body much better than I do. And, I might recommend a therapy and they have reservation. I guess I would explore what this gut instinct is saying. If there's a particular toxicity or concern that, the patient's fearful of starting this medication, you have to really have an open and honest discussion with your caregivers, with your healthcare provider, and make a mutual decision about what the next line of therapy should be. But certainly, I would never prescribe a medication that my patient does not want to take, but I would just explore and try and get to what that gut instinct is about. I mean, I've had recently in the last month a patient say that they didn't want to take erythropoietin, and I wasn't sure why. And when I explored it more, I learned that a friend had taken it and had a stroke. And I think you saw on the slide, thrombosis is a side effect of erythropoietin. But when I explored that with the patient, we found out the patient who had the stroke had other stroke risk factors, and their hemoglobin was much higher than my patient's. So I guess just if you can explore what your gut is saying, if there's a particular reservation, and then definitely communicate that to your provider. They should understand and be able to, either consider something else or just provide facts and information that might dispel whatever the concern is.
Thank you. Thank you, Dr. Phillips. And thank you again for sharing your time and expertise with us today. If you would like to watch, thank you. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. Be sure to visit the exhibit hall. The next educational session will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 38 years. This concludes the session.